session as informal as possible to enable people to, well, ask questions and get involved rather than us just rabbiting at you. But Peter gave a pretty emphatic segue of the history of NICE and the importance of its role in many regards in setting both the context for social value judgments and principles about how we apply health and social care across the country, but also making improvements. So thank you for that, Peter. I'll give a high-level overview. My name's Sarada. I work as an Associate Director at NICE, and my colleague Eric, I'll let him introduce himself briefly just now.
Sorry, yeah. Yes, I'm Eric Power. I'm a Programme Director at NICE. Normally I look at medicines and implementation issues, but more recently I've been leading up on our COVID-19 Rapid Guidelines programme.
And I should have mentioned that my area of focus is implementation support. So I hope that between us, we're able to at least get some discussions going. So on to the high level overview that I hope to provide. So I'm sure that those of you in the room are fairly familiar with what NICE does. Essentially, we produce evidence-based guidelines to improve health and social care and wider determinant practice. And we have a huge portfolio of work that covers guideline production, technology appraisals, reviews of medicines, quality standards, indicators, interventional procedures, a whole host of areas that we review and try to make assessments, or we do indeed make assessments of the cost effectiveness, the overall efficiency and effectiveness of these various areas. And we take into consideration a huge variety of things whilst we make those judgments. In terms of our view on implementation, we have a nice wide strategy. So we recognise that we can't do this alone, and that we need the views of both people that are experts in health and social care, those that receive health and social care, and wider audiences to make sure that what we're doing is right. And our 5 principles of our implementation strategy are quite clear: produce the guidance, ensure it's relevant, motivate and encourage improvements, highlight practical support, and I'll do that shortly, and evaluate the impact and uptake of this. And we do this in various ways. I mentioned our strategy, and that we try to ensure that our guidance is fit for purpose, and we motivate and encourage improvement through various mechanisms. We have a number of different teams across the organisation that support implementation at both regional and local level to do this. So some of you might be familiar with colleagues in the NICE field team, our Fellows and Scholars programme that tries to encourage health and social care and other practitioners to come on board and take on improvement projects with our support. We have medicines implementation consultants that directly support the production of guidance and guidelines. In my team, we look at implementability of guidance and try to advise appropriately whilst guideline committees are coming together and making decisions about recommendations. We have a host of similar support for technology and technology appraisals of both medicines and other tech, where we actually work on the ground with health and social care professionals that are trying to make use of guidance that we have developed and to see whether or not the things that we had stated are actually doable on the ground. And then we also try to highlight the impact that we're having through various mechanisms. One of the clearest ways that we've done that most recently has been through our impact reports. We've had a series of reports over the last 3 years covering a variety of areas, from lung cancer through to dementia, identifying indicators, evidence or data that shows what the uptake of our guideline recommendations has been and how far they have gone, and also the limitations in some ways. And my team work on implementation projects, trying to improve the uptake of our guidance on the back of what the impact reports tell us. I've mentioned the additional resources that we produce to try to make sure that implementation is real and not something that we leave in a corner. It certainly isn't. It's very important, and we recognise that it's essential to the production of anything that we do. And obviously that element of knowledge translation has to be guided by a multifactorial and multifaceted processes. And so we have these various additional resources that I've outlined on this slide just here. And I might come back to this just at the end. What might be most useful at this moment is to allow Eric at this point to take you through a very specific example of how we've responded to the pandemic quite rapidly and changed our own processes to ensure that implementation remains at the heart, especially of evidence-based practice. So Eric, I'll hand over to you just now.
Okay, thanks, Sarada. Yeah, so obviously COVID-19 is very topical. I guess from a UK perspective, if you're, this really came on our agenda in March. And for NICE, we very rapidly got involved in part of the national response to the pandemic. From a NICE perspective, we usually do develop a guideline between, I guess, initial commissioning and publication is about 18 months, maybe 2 years, depending on the priority. We can do a fast one in 12 months. And obviously in a pandemic situation, I guess there's a few things. One, you need speed. And I guess the second thing, you need to make sure you're doing things that actually are implementable and people want to do and want you to develop. So we got a commission from NHS England to develop our first set of 3 rapid guidelines, and we were given a week to develop those, and we turned that around and we developed a new process, a new approach, and a new way of doing it. And I guess it was an interesting experiment in terms of how we did it, how we maybe take forward some of the implementation for the future at NICE. I guess the first step is the commissioning of what's important. Now, NICE doesn't decide itself what it develops guidance on. It's commissioned either by our Department of Health or by NHS England or another kind of public body to do that work. So we do that on the basis of demand. However, I guess a pandemic is a really good way of getting people telling you what is an absolute priority and moving quite rapidly to what develop guidance of the kind of priority topics. I guess NICE's usual world is exploring the evidence and coming to quite deliberative conclusions. And I guess the COVID-19 pandemic was one of those positions, I guess particularly at the start, where we didn't have very much by way of evidence. So we had to develop a new way of working, which was both rapid, tried to bring in evidence where it was available, and could rapidly respond to changes in evidence. So since March, we've developed 20 rapid guidelines, some of them around some elements of treatment, some around how services should be changed to support people in the pandemic, and some about how we manage people with long-term conditions that might be particularly relevant. And I guess one of the other things we've done is we've done 58 kind of significant updates to our recommendations over that period of time. So we did say we were going to be quite responsive. So Sarada, do you mind popping the next slide on? In terms of our development process, in NICE, this is kind of our standard development process. And during the pandemic, we pretty much kept to the entire process. So we still developed a scope that we wrote down. We agreed it with people, and then so in this case, we agreed with NHS England, who is the lead for implementing the response to the pandemic. We had a development process. We ran a consultation. So our usual consultations run for about 12 weeks. I think in some weeks we ran them for 6 hours, with some very targeted groups of people who potentially were the most relevant in terms of commentators. So that included patient groups, professional societies, and I guess healthcare professionals, and the overall service or policy part of NHS England. And then we went out, updated, went through a quality approval, quality assurance process, and then a publication, and as I've just said, a regular updating. So it's been really interesting. We've managed to do this and turn these things around quite quickly. And you would think, 6 hours or 12 hours to respond to a document or recommendations. We were getting 100 plus, maybe 200, and even in 1 or 2 guidelines, we've got 300-400 comments to back on our guidelines. So, people were very, very engaged in the work. So, Sarada, do you mind just popping on the next slide? So I guess, as I said, implementation was there from the start. We were really trying to answer the questions that people had. And I guess in the context that we were working in, particularly at the start of the pandemic, there wasn't much information, and many people were trying to come up with something and to doing, I guess, natural tests and just seeing what might work. So we had a really interesting example about procalcitonin, which is used potentially has a role in determining if there's a bacterial infection. And we had some existing NICE guidance, which we call DG18, which suggested that actually it wasn't particularly relevant. However, there was a huge amount of interest from frontline clinicians, particularly those working in intensive care units, to see what was available. And there were some studies that were out there. So we commissioned a very, very rapid review of all of that evidence and incorporate that into our guidelines. So we got our diagnostics program. So rather than that being a separate piece of guidance, we drew that into our rapid guideline program. And actually what the advice was is really you shouldn't be using this in the way that was being promoted by many people at the time, because there wasn't really the evidence that it could tell the difference between a COVID-19 infection with COVID-19 pneumonia or a regular bacterial pneumonia. It did seem to tell other things, but it didn't tell you that information. And we came up with some research recommendations. And in terms of that, taking things forward, we did have some people who maybe weren't very happy with it, but what it has done is supported the sites that where they were being used to go ahead and to be part of some of the wider studies on this, so we could actually generate some of the evidence that was coming out. So I think I've got one more slide left. So implementation was there from the start. We were heavily involving people who were working on frontline. So that was people working in intensive care units, on admission units, in supporting us with the reviews. And there's a nice quote there that's from our most recent impact report, which we took to board yesterday, from a clinician in Manchester, who said, you know, we got the guidelines out there, it supported the uptake and was very, very relevant. I know being a kind of an academic type seminar, normally we would like to have lots of data and information. We're still picking that information up. However, what I can say is we have had a huge amount of feedback from the people we're working with in the national institutions and through our associates network and through our field teams, that actually what we're doing is meeting the needs of people and they want more and more and more. So I'll stop it there because, and see if you want to have a bit of a conversation about any of the things that we've talked about. Sarada, just while we're kind of getting going, I mean, have you found that people have been, when you've talked to people, because you obviously engage with some of the national programs, how they feel that NICE has supported them over the last, I guess, 3 to 4 months, and how that support, I guess, the implementation of best practice in the management of COVID?
Yeah, it's interesting because most of the conversations I've had have been where we've done direct implementation project work. And so where areas of that type of quality improvement work has slowed right down, the feedback I've had from various people involved has been the only organisation that they know that they can really turn to for quick advice has been us in this time. And it's been incredibly helpful to have very rapid access to information that's evidence-based, it's clear, that's helpful. So we've had really positive feedback at this point, though it's been ad hoc and piecemeal. We haven't done any evidence-based or qualitative research into this at this stage, but it has been very positive. But it'd be really useful to hear from other people in the session at this point, their thoughts and opinions about what we've put out there over this time. If I can encourage people to do that.
Could I just have an observation and perhaps a question where other people are thinking of theirs? A fabulous presentation, and I think you reinforced very strongly that you need a process, but it doesn't have to be the same process. You can take the principles and then adapt the process for the timescale, and obviously getting something out quickly was absolutely crucial for COVID. But do you feel one of the criticisms of NICE in the past has been it's taken very long to produce guidance, it's gone through its processes, evidence-based consultation. Do you think there'll be pressure now to actually adapt and continue this mode of working rather than going back to the more traditional NICE approach?
Yeah, I mean, you probably summarised our public board meeting yesterday, where the non-executives were asking, can we do that? I mean, we're absolutely looking at what we can learn. It's interesting, we're currently developing a guideline on, I guess, safe planned care processes. And what's been really interesting is the volume of material that's of published material is now much, much bigger. it's probably easy to be very quick and reactive when there's not much evidence, because you're almost doing what is just general good practice principles. As the evidence becomes available, you do need that more deliberative approach as you go through it. So yes, we are doing a big piece around the learning that we can do and thinking about how we can speed things up. And there's probably some stuff you can speed up, and there's other things like where you bring in health economics, or you need to do really deep evidence reviews. You need to spend the time to do it, because the opportunity cost of getting that wrong can be very, very serious for people. You know, thinking about things like diabetes or heart disease and things where you're talking, you know, obviously hundreds of thousands, millions of people even across the country who this affects. But I mean, I know similarly there must be pressure on NIHR as well to do something similar to that, in terms of, I know that we've been working closely with them in terms of some of the new treatments coming online and looking at the NIHR studies and how can we rapidly turn those into evidence-based guidance, or to support the development of evidence-based guidance. And are you seeing similar pressures on yourselves, Peter?
Yes, I mean, the NIHR, like every other institution, has directed all its efforts very quickly towards COVID. But I think there's also the view that, as you know, in NICE, you will know the significance of opportunity costs. And by directing too much to COVID, then you may actually be jeopardizing you know, health of many other groups over the long term. So there is now that balancing out of looking at the portfolio and getting the balance between what's COVID active and what's moving forward. But I think just perhaps while you're on the line, so to speak, I presume very little economic analysis went into the COVID guidance. It was more providing support for clinicians having to make very significant decisions very quickly. But is there any plan perhaps to build more economic analysis in as things settle down?
Okay, yes, you're absolutely right. We deliberately changed the method, so we didn't do economic analysis of the guidance that we were developing. And I think it goes back to, I think, what was said in your previous session of, there was a political view that it's whatever it takes, was the push, and definitely from our commissioners. I think in reality that for most of the guidance, it wouldn't have added much by way of value anyway, because there wasn't high quality evidence about what would be effective. I think looking to the future, you can definitely see that will become more and more important, particularly as I guess COVID moves from being, I guess, in the pandemic, as we kind of call it at the moment, into a more endemic situation, and how we manage that as part of routine care. So absolutely, in terms of the new guidance we're developing, just the outside of non-COVID guidance, so the existing program of work or business as usual work, we are now going out to consultation and asking people if we've missed anything. Has the world changed that we need to, and the context? And part of that probably will be does that change the economics around some of that? Are things that you take at home worth more, that we don't have to come into hospital and have a procedure? Is that a higher value? Has it changed and probably has at least temporarily changed the cost structure of providing care? In terms of hospital care, is a lot more expensive if you look at the cost of PPE costs and the reduced throughput that we can get through various services because of the requirements for cleaning, additional cleaning, and all the other measures we need to put in place to keep things, as they call, COVID secure.
Can I just
Mark has put a question in the chat.
Yeah, I just noticed that. I just wanted to pick that up, Eva. The question is from Mark Pearson, which is, to what extent is the involvement of stakeholders important for the implementation of guidelines? By which I mean the involvement of stakeholders in guideline development. Just from the very outset, and I'm sure Eric will contribute, and I'm sure Peter will too, actually, on this point. It's absolutely crucial. It's one of the key stages of guideline development. I'm just thinking about knowledge translation and the push factors, which NICE are very good at encouraging. One of the areas that we highlight through the process of development is the opportunity for stakeholders to send significant commentary on both the guideline recommendations that are produced through development and also on the resource impact tools. If you've not seen them, they are intended, their intended audience is NHS or health and social care providers and commissioners, so that they understand the cost impact, the direct cost impact of any of the main key recommendations that we've made in specific elements of guidance. And there is opportunity for really meaningful stakeholder involvement through consultation in both those areas. But Eric, I'm sure you'd want to also add in some more points there.
Yeah, I mean, I would just reiterate. I think you said most of it, Sarada. I mean, it is the key thing. I mean, the guidance is meant to be useful for people, and it's meant to be implementable. And really, you get that through your stakeholders, isn't it? And we are thinking about, we're constantly thinking about how we do involve stakeholders in our work. And it's going to be a kind of a key theme of the work we're taking forward, which we call NICE Connect, which is about, again, bringing the information that is kind of the focused implementation or information in terms of the recommendations nearer the surface, so that people know exactly what it is we're saying is the most effective things to do, most effective ways to provide care, I guess.
I can't see any other questions on the chat. I wondered if anybody was brave enough to ask them on the video.
I don't want to hog the scene, but if there's nobody else, can I just ask another question? You presented the very broad portfolio of NICE guidance, and much of it is obviously clinical, but there's also social care and public health. And I just wondered whether the emphasis for COVID was much more around clinical management than some of the more thornier public health issues around masks and whatever. And was NICE involved with that as well, or was that tend to be Public Health England and other institutions?
Yes, so the commissions we've taken for COVID have all come via NHS England, so they are healthcare focused commissions in terms of the pieces of work we've taken on. I guess Public Health England leads on the infection prevention and control type part of the system, so we have stayed away from that, just because it doesn't help if we say anything different. And I guess what's really interesting in a pandemic is the approach is probably quite different. You don't want to go, whereas sometimes we may say things slightly differently to other institutions, national institutions, or look at it in this environment. It doesn't help to give people mixed messages, because ultimately it's a big command and control in terms of how this is run on an operational basis. So we stayed away from that. However, we have brought public health into England representatives into the guideline development process, where there were significant recommendations that will be around infection prevention and control. And yes, we haven't done anything on masks, probably from a personal perspective, thankfully, because it's obviously a very, very thorny area, a very interesting area, but a very thorny area of practice. Yeah.
Thanks very much.
I don't know, Sarada, is it worth saying anything about how we do engage with some of the stakeholders? I think that's quite an important piece of work, isn't it? And you and your team are heavily involved in that.
Yeah, I think that, coupled with, there's probably others that do this more justice than we do in my small team at NICE. But essentially, I guess there's two lenses to look at this. We're currently going through our own transformation program internally. We've had we have a biannual implementation survey where we get feedback from stakeholders across the country with regards to how, and devolved nations that we serve, Wales and Northern Ireland, with regards to how we are doing, how relevant our guidance remains, what more we need to be doing, areas that we could be improving on. And we also, so whilst we take that into consideration, we've got a transformation program ongoing. The way that we gather the information from stakeholders at the moment remains how it has been for many, many years, which is that we go out to consultation, seek feedback on various areas of what's important. I very recently sat in a guideline committee for a guideline that's due to be published on perioperative care. And the whole purpose of that particular committee meeting was these stakeholders that have, health and social care experts that have been around the table for quite some time developing this guideline, were really keen to understand how implementable, how realistic is what we're doing? What do our stakeholders? There were 790 comments and they went through all of them and it was painstaking, and I was sat around the table with them doing that. And my perspective was to challenge on implementability. So I recognise the various areas, what's aspirational, what's best practice, but how doable is some of this stuff? How practical is some of this stuff? And that process is applied through each guideline that's developed, and not just the clinical guidelines that we produce, but equally the other areas, including social care, public health, and our interventional procedures program for surgical procedures, etc. There's always this process of ensuring that stakeholders are consulted on. Some of my colleagues will say that there are methods that involve co-production that we don't always embrace that well. And it's a question for us to really ponder over, something that we are looking at the moment.
Thanks. I think we're up, are we? Time's up. I think.